conflicting information between one doctor and another. How do we ensure that we don't waste valuable time? Because I know with disease, early diagnosis and finding the disease is crucial and important, and sometimes can even be a matter of life and death. But here we have a case of somebody who was given one diagnosis, went to Kenyatta, and they gave him something different.
No, you see what happens with kidney disease. One, you have to assess and see whether is it something acute that just happened at that point in time. Is there any chance of anything reversible as well? As I told you, the different stages of kidney disease. So somebody, his risk factor was, we found out later, was hypertension. Mm-hmm. So hypertension can predispose you to getting chronic kidney disease, and unfortunately it's one of those silent killers that we have, very prevalent in Kenya as well. Mm-hmm. So sometimes there's, like, you can be in stage 4 of kidney disease and you get a small infection, bacterial infection that can tip you over into stage 5 kidney disease. Now at that point in time, now you have to decide whether yes, you can give the patient some time and see whether you improve the blood pressures, treat the infection, and the patient can go back to its pre-morbid stage, which is stage 4, mm-hmm. and avert dialysis for some time while we now look at other things like access and a preemptive renal transplant. Mm-hmm. So this is what I believe. Okay, I'm just trying to see what, I was not there in Kenyatta, but possibly that's what they were trying to do, and see whether they give him some time and he might, with the right medications in terms of improving your blood pressure and removing all other insults to the kidney, you can get back to a stage 4 or a stage 3 kidney disease, and then we can be following up very closely after that. So sometimes that we tend to do it, yeah. But the only thing is that the patient has to be on a very close follow-up.
Okay.
Yes.
All right. You've talked about the different stages of kidney disease. Yes. Maybe just run us through those different stages.
So the staging of kidney disease currently is based on what we talk about, the glomerular filtration rate. How efficient the kidneys are in terms of clearing. So the rate of the filtration through the kidney. And we use that by, we calculate that by using the serum creatinine, which is found in the blood. So we have stage 1, which is more than 90 mils per minute, and 60 to 90 mils per minute is stage 2, then 30 to 60, then 15 to 30, and less than 15 is now your end-stage renal disease, or stage 5 kidney disease. But the current classification has also added any structural disease. So for example, if you are born with one kidney, you're also classified as having a CKD. If you have any proteins in the urine that are persistent, you're also classified as having chronic kidney disease, because there is some structural damage that has happened to the kidney. So that's how it's classified currently.
All right. Nikuje kwako Zachary, na sasa kutoka uanze dialysis, unaifanyia Meru ama inabidi unakuja Nairobi?
Nilikuwa nafanyia Meru.
Na sasa bado unafanyia Meru?
Saa hii sifanyi.
Umeacha dialysis?
Niliwaza siku ile nilifanyiwa operation.
Okay. Sasa hebu tuambie sasa kuhusu operation. After dialysis uliona ni kama mwili hai-improve,
nilikuwa mwili hai-improve. Sasa nikaambiwa niwe na tafuta ndona. Na wakati nilipata ndona, sasa tukaanza process ya kufanyiwa vipimo. Tulikuwa tunafanyiwa Khan. Na baada ya kufanyiwa hiyo vipimo yote ikaisha na ikawa ni sawa, tukakaa zaidi ya miezi 2 bila kufanyiwa transplant. Sasa wakati hiyo ndio niliongea na daktari ambaye tulikuwa naye Khan. Nikamwelezea hiyo bila kumekaa sana, na tulikuwa tunamaliza kila kitu. Sasa nikamuuliza kama naweza enda nifanyiwe mahali ingine. Akaniambia ni sawa. Ndio tuliweza kuenda Mpisa, na wakati hiyo hao hawakuchukua hata muda. Nafikiri kwa 2 weeks nilikuwa nafanyiwa. Nilikuwa naambiwa nitakaa 18 days. Lakini nilikaa hospitali siku 4, ya 5 nilitoka. Na mabadiliko tu ilikuja wakati niliwekwa kintini siku hiyo. Nikasikia hata mwili imebadilika.
Okay. Daktari, yes, let's talk about interventions and solutions. He's talked about dialysis. When we go through dialysis, what is the dialysis addressing?
So basically, the dialysis is trying to take over the function of the kidneys. So it's like an external kidney that you go, you get yourself. It's a machine basically that you get connected to. The blood runs through the machine. It gets purified. All the wastes are removed, and subsequently it goes back into the body. So that is what we call hemodialysis. Then there's another form of dialysis which is not so popular in Kenya. It's called peritoneal dialysis, whereby we put in a catheter in the abdomen, and it's basically done by the patients at home. And the patient puts in the fluid, it stays for 4 hours, and then subsequently the patient drains the fluid and then puts in another fluid, and it stays like this for 4 hours. And at night, the patient puts in the fluid, stays the whole night, what we call the long dwell, and gets up in the morning and drains it. So those are the two forms of dialysis that you have as part of the renal replacement therapy. The main problem you get with hemodialysis is that we have to have an access. Like either what we prefer is a tunnel catheter, which is under the skin, and we do a fistula as well, where we connect the artery to the vein at the same time. So it takes 6 weeks to 3 months for that fistula to mature, and once when it starts functioning, we remove the catheter. But again, you can get problems with the fistula as well. You can get the fistula not functioning, you can get the fistula clotting up or becoming narrow, and it requires more intervention as well. So the best form of renal replacement therapy, and it has been shown internationally as well, with patients surviving better, is of course the renal transplant. Yes. So
okay, and with the dialysis, how accessible is that in our hospitals?
Well, currently with the National Hospital Insurance Fund, which was initiated by our government, I think that has been a life-saving initiative by our government. Because I remember in 2015 when I came back from South Africa, before it was rolled out in all the counties, it was a major headache, because even in the provincial hospitals at that time, that we used to call them provincial hospitals, the dialysis used to cost 6,500 Kenyan shillings for every dialysis session. And NHIF was not paying fully the whole dialysis session. So, and you have to do it a minimum of twice a week for the rest of your life until or unless you get a renal transplant.
Wow, twice a week?
Twice a week minimum.
So once you start your dialysis, there is no stopping?
Yes, if it is a chronic kidney disease and the kidneys are irreversibly damaged, then there's no stopping until you get a transplant. There are some cases where you get acute kidney injury, possibly because of malaria or an infection, or you get a very bad gastroenteritis, diarrhea and vomiting, and but sometimes those we put them on dialysis short term, we monitor very closely, and